I wanted a cone beam 15 years ago. I salivated over it. I like the Planmeca Panorex. We're going to talk about, guess what? We've just moved from being paperless to digital x-rays. Alright? Now here's the deal. Do your patients love having that thing shoved in their mouth? Are we at the level we can take extraoral x-rays? Nothing in their mouth? Are we there? We are. We're talking panoramic extraoral bite wings, panoramic periapicals in the anterior. We're talking, instead of owning 4 sensors at $10,000 a piece, only own 2. Not paying that $1,700 a year to insure a sensor that Susie's going to suck up the vacuum sweeper. It happened to me. Okay? Alright, so here's what you can live with. Would you rather have this or that? Alright, let's talk about radiation. Okay? On a kid, if you take these 4 x-rays like this with a digital sensor, the best one you got on the market, the kid's going to get 20 microsieverts of radiation. Okay? Now, we went digital, we cut radiation by 80%, right? When we went digital. How about this? If you've got 4 of these, 20 microsieverts, you know how many microsieverts that is on a kid? 5. 5 microsieverts. You can have all that information for the same radiation as 1 bite wing. I think it's a no-brainer. This versus that. Let's look at this. Here I got a guy right here. He came in for his pan. Nice Panorex 2009, all digital pan. And we always worried about, can you diagnose decay up here in the anterior? Okay? You know, Panorex is 25, 30 years ago. We had them for one reason, to count teeth and send them to oral surgeon to get their wisdom teeth out, okay? Or before ortho. They just recently said, the ADA said, pre-screening for a TMJ treatment is a Panorex only. That's a bunch of garbage. If you're treating TMJ off of Panorex, you're going to miss a lot of stuff. Alright, here we go. Here he is for his appointment yesterday. I got this information. That's a bite wing. Nothing in his mouth. Here's his periapicals of his anterior teeth. In focus, you can see decay. You don't need to stick the sensor in the mouth. Stop and think about the productivity here. That's the side light. This takes almost no time at all. Alright, how about the radiation overlap? Now I do this way. I'm going to do it and you're going to hear me go. Because here's the deal. Do you really need a lead apron for people when you take panoramic bite wings? All the radiation's above their Adam's apple. It never goes down this way or this way. It doesn't bounce off the fluids up here. It doesn't get the thyroid. Here's your radiation overlap. See this here in red? If you take 18 films, that's every shot you take. Okay, that's just the first shot and not looking at the secondary overlap. What areas are getting radiated twice? There. How about 3 times radiation? There. How about quadruple radiation? There. And there. 5 times the radiation. Just to get your typical full mouth series, whether it's digital or not digital. Alright. Alright. Look at what you get with just bite wings. Alright, let's skip to this one. Alright, look at this. What I did was, I shot this just in, this was just in EagleSoft. You've got to set your Twain things just right to get it right. I shoot a lot of stuff in Romexes. Do I see that there's periodontal problems here? Do I see the decay here? See, the Romexes, which is the software of Planmeca, is very robust and you can do things. It actually takes 10 layers. And they have what now is called the Smart Pan, or they even have another development now, is where they've cut the radiation by 80-some% in taking cone beams. So now you can take a 3D cone beam of a maxillary molar. Get this. I can get second bi, first molar, second molar, 3D for the same radiation as 3 periapicals. Would you rather see it in 3D? Look at this. Look at our nerve there. Now, a lot of guys still put in implants just using a Panorex. I'm not there. How about this patient here that's got these tori? Do they like having that thing shoved in there? Now in the old days we had film. We could bend it, couldn't we? Right? We could bend the film. And it was thin. And it would come around the corner and you could get close to it. The number one downfall of digital intraoral x-rays is the distance you have to be from the x-ray. The farther you are from the sensor, the poorer quality the x-ray is. See, in the old days you could lay the film right up next to the vault of the roof and you could put that down there, you could turn the KVEP up, go, you know, until the room lit up and you could see everything that was going to be decayed in the next 20 years. Here's my tori. How about you take this on her? You want this x-ray or you want that one? 1/4 the radiation for that versus that. Look at what you're missing. Did I get the distal of a cuspid? Yeah, I did. But did I get the bone up here? I didn't get the bone there. Did I get the bone over here? No. Did I get the bone there? Yeah. Okay. How about here? Which would you rather have? Now, I know there's different brands of Panorexes, and if you're going up to Midwinter and you're looking and shopping, there's only one unit out there where when it takes a bite wing, everybody from Serona and all the other folks are talking about how they can take a bite wing, okay? And it's on the same rotation as a Panorex. It goes only one unit comes in like this. It's called Sclera technology. It's a robotic arm that squares up the sensor parallel to the arch and truly opens it up. The best one out there, and the literature's starting to prove it, to plug cone beams and 2D for planectomy. Here we go. Do I need, when somebody has a toothache, I'll get a new associate in, and somebody walks in and they say, well, it hurts down here. Well, Debbie, take a PA number 18. Why in the world do you take one x-ray of one tooth when they have a toothache? What if they're missing teeth over here? What if they got perio here? Yeah, I can see the abscess. Okay? So why not have a Panorex? I don't care if they can't afford it. What is the best way to document a patient's condition the first time you see them? For less than a nickel of electricity, you have a picture of everything the way they are now with the same radiation as 2 periapicals. Are you kidding me? And then you can start talking to me, hey, you're missing teeth here, we should replace this. Oh, your sinus is down here a little bit. If you want something, you want implants? Okay, yeah, fine, we got to do a sinus lift, okay? You got all this stuff in front of you. It's automatic in my office. If I've never seen you, and you walk into my office and you say you've got a toothache, you get one of them babies. Automatic. Well, doc, they don't have any money. I don't care. What if they like to sue people that they don't pay? And they say, well, that Dr. Jesek, he screwed up my mouth. I went in there and I had nice teeth until he worked on that one tooth right there 25 years ago. He's a lousy person. Oh, well, let's look at the x-ray in court. What if you have a patient in, and here's the other thing. If you've been in practice as long as I have, you have what's called familiarity, you know, and you start getting lackadaisical and you start saying, you know, I did that crown 10 years ago, it's got to still be good. I did that filling before I had gray hair, there can't be anything wrong with it. Now let's let her go another 2 years, okay? Well, what if you take this set of bite wings, or if you take that set of bite wings? What do you see? You see the widened periodontal ligament, you got a hint here, but the digital x-ray isn't big enough, is it? That isn't. Now if you had an old film one, you'd probably see it. Look here, we got an abscess, right there. Well, by golly, wouldn't the patient rather have me, oh, hi, Mildred, you got an abscess tooth down there. By the time you get ready to go to the Caribbean, it's going to blow up, your face is going to swell out to yonder. Why don't we get that done before it hurts? Okay. Well, doctor, you have such cool stuff. How about on 7-year-olds? Wow, I love it. I send kids home with this. Now, do I use expensive printer paper, you know, photo paper in my office? Heck no, I use copy paper. You know, print all your x-rays and stuff on copy paper. Why? Can you hold the paper? Oh gosh, doctor spent $1.85 on this beautiful Kodak paper. Yeah. Can I shine, Debbie, can you shine the light on that so I can see it better? No. Hey, look at it digital. How about a 5-year-old? Look at all that, are you seeing the decay? Here, here, here. You know, even if they wiggle, it'll only blur like maybe like they did right here. Okay? Look here, this is my pet peeve. Teeth should have been extracted, right? I love it when people keep deciduous teeth. Look what happened. Second molar didn't get to erupt, did it? You talk about a control group. Here's your control group. First molar on this side was lost. Second molar, deciduous molar, was lost timely or pulled. This one said, oh, we got to keep it in there because bad dentists pull teeth. And there's no permanent tooth under it, so we're going to wait until they're 45 and then we're going to pull it. And then we're going to put an implant in and we're going to hit their nerve, they're going to have enough lip for the rest of their life. Or we're going to put a bridge in there, it's going to have to be replaced 3 times in their lifetime. Why don't you take that tooth out when they're 7 years old? Let the teeth move forward, no more orthodontics needed. And guess what? You know, I've got some slides where the wisdom teeth are impacted. So here's what you do. You keep the second deciduous molars. Not only does the second molar not get in, you have impacted molars. So what you're sending a kid for is four molars to be extracted, and then to try to upright a second molar. Also, you can save a deciduous molar. I just took a deciduous molar out on a 55-year-old guy yesterday that had a crown on it. It didn't bother him until somebody put a crown on it 4 years ago, and then it abscessed. All right, let's look at this one. You want some pucker power? Here's a physician who's always in a hurry. Doesn't want to take time for x-rays. You say, oh my goodness, look at that little spot right there. He comes in and he only wanted bite wings from 2004 and to 2012. Debbie grabbed him on the way out and said, doctor, we need to take an x-ray. What do you think of that? Do you think I started breaking a sweat? Fortunately, I had sent him to an ENT and they were supposed to keep track of it, and Dr. Good Guy was too busy. It was an odontogenic keratocyst, but it expanded the ridge big time. So if I would have taken panoramic bite wings on him, I would have caught that, wouldn't I? Because I had bite wings on him this entire time. How about this one? I've known her since all my life. She's a good friend of mine. She's 59 years old. She's a radiation phobic. Don't take any x-rays on me. Just wisdom tooth. I said, Paula, someday that's going to get you. This is all she let me take since 2006. Bite wings only every 2 years. I said, okay, we got a new machine. We're going to take bite wings on you. Whoops. Another whoops. Right? Paula, I have a new machine that I can take a CAT scan on you for 1/20th of radiation, a hospital CAT scan. Let's do it. Let's look at it. Where's it at? Right there. Okay? She hasn't had it out yet, but my oral surgeon is going to have a copy of that. Look right here. Okay? Why should I think every general dentist and specialist needs to have access to cone beam imaging. Why? When does a GP take a bite wing versus a panoramic image? Which is better? I like the panoramic. How many of you are putting your own implants in? Anybody yet? Okay. I started 5 years ago. I make my own guides for these. These are Lodi's. I'll just go through this really quick. You denture duplicate this thing. You put gutta percha in there. You take a cone beam, and now you know you're right over the ridge. Okay. You can mark the nerve. The other thing of it is these lines are every millimeter, so you can now say, okay, I need these 7 millimeters apart from center to center. Okay, I got to put it 5 millimeters in front of the twist on the mental nerve, so I'm going to do that. Mental nerve's there. I make my own, but I'm sending them out to these guys. If anybody here use a denture duplicator? Really? Mrs. Jones has had her teeth for 15 years. She loves them. She wants you to make a new set. Why don't you duplicate her set, reline them, and you don't have the next visit to try in. She likes them because they look just like her old ones, or she can't stand her teeth because they make her look bucky. So you duplicate the teeth she has. You take a facebowl mounting, you put it on the model, and you say, okay, your teeth are bucky. Okay, watch this. I'm going to put them back here. So you can either study. I have study models or casts of people with dentures. Okay, this is me making my guide. That's the gutta percha. I got a little over it. See, this is a different splint. See where I'm at? This is I was back in the floor of the mouth putting these implants in. The tissue was wrapping up around the twister. They're in fine. But look what I got. There's where I'm going. There's the 3D. Single tooth implants, a lot of us are doing this. It sure gives you a lot more confidence if you know where the nerve is. You can pre-plan it, and this is what you're going to send off to the lab like Ottawa. You take the x-ray, they're going to call you on the phone, they're going to talk to you, and then they're going to say, okay, I want to put this in, my nerve is here, I got my implant's going to be 11 millimeters long, I'm going to be, well actually here I'm 8 millimeters from the nerve. That's a lot of confidence, knowing I put it in, wanted to make sure it was in the middle, I didn't have it in all the way, I took this cone beam, I took it down a little farther, I was confident, but here's it, they use co-diagnostic, so they can work with any panoramic or cone beam. So you got a guy across the hall, you got somebody that's got a cat's iCat, Plan Mecca, Scientific, whatever, Kodak, whatever they got, you can email them the stuff. They can make you models. They can print you the guides. Because here's what's going to happen: if your specialist is doing this, and this is a learning curve, but see, you know it's dead center of the bone. You know you're not up in the sinus. You got a guide. They print it for you instead of having this big monstrous guide. You go in, and they make you something like this. They put the metal sleeve in there. You've got the sleeves and the navigator system for 3i, and so forth, etc. And so what you do is you got the plan, and you come up with something like that. You're not screwing into the roots. You're not going out the buckle plate. You're not too far lingual. It's in the right place. Okay, and then they're in Ottawa, Chicago, and in Bloomington, and then you've got the thing. And this is me. Kid comes in, he's Amish. He's got some decay here. I took a comb beam. Let's look at him real quick. I could see the decay here. I couldn't see all this. You know, should I pull the tooth? Absolutely. What's it look like? This was the panoramic unit with the comb beam, part of it. This is what the tooth looked like. All eaten out. That's what it looked like again. That's what it actually looked like. It's a combination of external resorption as well as decay. How about missing a mesiobuccal canal? This patient, this gal, works for Plan Mecca. She'd had this tooth treated endodontically, conservatively, conventionally twice, and had it had an apioectomy. Look what the problem is. Missed the mesiobuccal root there. Okay. I was doing a root canal the other day, and I couldn't find the distal buccal root on the molar. I thought I was going to go out. I took a comb beam. I figured out I was 2 millimeters short of it. I went I literally spent 5 minutes looking at the comb beam, went back in my office, got on a number 6 round, went back 2 millimeters and dropped right in the canal. Okay? But see here? That's what you can see. So you've all been there. Patient comes in, tooth gets treated, gets retreated, gets extracted. How about doing non-bloody surgery, exploratory surgery? That's what a comb beam is. You don't have to lay a flap and see if the root's fractured. You don't have to lay a flap and see if the buccal plate's gone. You don't have to lay a flap, and I'll tell you what, you take the comb beams with some of these abscess teeth, you say you need an implant. Because it abscess. How about this gal? She was, hey, anybody know the bad stuff about electronic cigarettes? They're awful, okay? They're terrible. They're worse than regular cigarettes. This is a beautician. I did this root canal. It was not overextended. This is what she looked like after having her braces done. We tipped it a little bit. Guess what? She went through the buccal plate with the orthodontics. I use a good orthodontist. There's a gutta percha sticking out. But look at the periodontal defect. You know where she held her electronic cigarette for 1.5 years? Right here. Dr. Norian says that it's even worse than, it's not the smoke or the tar, it's the nicotine. So how about TMJ analysis? I take for about the same radiation as 2 Panorexes, I take a comb beam, it's called horizontal pair. There's a Panorex. Something's wrong over here. This gal's yelling that the dentist screwed up her bite because she made her teeth too short. And so look here. See here? She'd had these teeth crowned. Oh, she made these teeth too short. Do you notice the difference in the height in the distal axial wall? What do you think's going on in the condyle? This right here. Whoops. She wanted me to crown every tooth in her head because the dentist before me had screwed up her mouth. She wanted me to crown every tooth in her mouth because her teeth were too short on this side. I said, guess what? That's where they're going to be. Because the condyle is going to dictate the size and everything. Okay. Look at this. Does that look like, do you want to put a bunch of crowns on this person? Okay. And for your orthodontist, when they're looking for an impacted canine, it's marvelous. Sleep apnea, this is me, for those of you doing sleep. Let's see if I got that. This is me with my teeth in maximum intercuspation. This is me with my snore guard in. See how the difference? You can actually measure that volumetric. See the difference from here to here? So, you know, even with my 8 and it's time. Okay.